Welcome back to the Deep Dive. We're here, as always, to cut through the noise and give you the essentials from, well, pretty complex sources. Today, we are doing a deep dive into infections of the skin, soft tissue, and even the musculoskeletal system. We're pulling the key info straight from Chapter 14 of Microbiology for the healthcare professional. Now, if you work in healthcare, or maybe you're just super curious, this stuff is fundamental. I mean, the skin, it's your body's largest organ. And as our source points out right away, it's really your first massive line of defense. So our mission today, quickly boil down the science, the terms, the microbial tricks you really need to grasp.
It is a remarkable system, the skin, but it does fail often. And when we look at how microbes cause skin disease, we can kind of break it down into three main ways. First, the obvious one, an organism gets in through a break, a cut, a scrape, a breach in the skin's integrity. Second, you get systemic infections. These start somewhere else, maybe the lungs or the gut, but then they show up on the skin, like those rose spots you sometimes see with enteric fever, that kind of thing.
Right. And the third type, the one that maybe isn't as obvious.
That would be toxin-mediated damage. So the bacteria might just be in one spot, maybe a small infection, but they pump out these really powerful toxins. These toxins get into the bloodstream and cause damage, far away skin damage, sometimes necrosis, or even sheets of skin sloughing off. Toxic shock syndrome, with its rash and peeling skin, that's the classic example.
Okay, so to really understand how these infections work, we need to visualize the battlefield first. The anatomy.
Exactly. Before we dive into the bugs, let's map out the layers. Starting from the very outside, you've got the epidermis. Now, this isn't just dead cells, it's 5 layers of epithelial tissue. And importantly, it contains specialized defensive cells called Langerhans cells.
Langerhans cells. What do they do?
Think of them as guards. They're dendritic cells, part of the immune system, constantly checking things out. If they spot an invader, an antigen, they grab it and kick off an immune response.
Ah, so the epidermis is like an active surveillance zone, not just passive armor.
Right.
Got it. Okay, below that.
Below that is the dermis. This is the thicker structural layer. It has 2 parts, the papillary and reticular layers, and this is where all the action is, really. Blood vessels, nerve receptors, hair follicles, sweat, and oil glands, it's all packed in there. Plus, it feeds the epidermis above it.
Okay, dermis, and then the deepest layer.
That's the hypodermis, or subcutaneous layer. It's mostly loose connective tissue and lots of adipose cells, fat cells, basically. It connects the skin to the underlying muscle and bone.
So epidermis, dermis, hypodermis. That structure is key. But historically, well, humans weren't always great at respecting that barrier, were they? This brings us to a really fascinating and, frankly, quite shocking story from medical history. Ignaz Semmelweis, back in the mid-1800s.
Oh, it's foundational. The context is just grim. You had physicians going directly from doing autopsies.
On patients who died, often from sepsis.
Right, directly from that to the maternity ward to examine women giving birth without washing their hands.
They even wiped residue on their coats as a badge of honor, showing how busy and experienced they were. It's unbelievable.
And the result? Puerperal fever, or childbed fever, rates were astronomical, sometimes over 30% mortality in certain clinics. Just devastating.
Semmelweis saw this. He connected the dots. He thought, okay, this stench, this cadaverous material, it must be carrying something. We know now it was bacteria.
And his solution was simple, empirical. He made doctors and students wash their hands with chlorinated lime solution between patients.
And the results were dramatic. Death rates plummeted down to around 1%. You'd think he'd be hailed as a hero, right?
He was attacked, ridiculed. The established medical community just couldn't accept that they were the source of the disease. It challenged their entire status.
Which led to this term we still use.
Yeah.
The Semmelweis reflex. That knee-jerk reaction, the automatic dismissal of a new idea, especially one that challenges dogma, without even properly looking at the evidence.
Exactly. Luckily, his ideas didn't die. Joseph Lister, who we often call the father of modern antisepsis, picked up on it later.
Lister knew about Semmelweis, yeah. But he had a slightly different approach.
He did. Lister thought it was about the odor, the putrefaction. He started using carbolic acid phenol to clean hands, instruments, even the air in the operating room, trying to kill the source of the smell, which, well, happened to be the microbes.
And there's a neat little side note in the source about surgical gloves, too.
Yeah. Apparently, Lister's nurse developed really bad contact dermatitis from the constant exposure to carbolic acid. So Lister asked Charles Goodyear, yes, that Goodyear, to make rubber gloves just for her. The first surgical gloves.
Amazing. So this history lesson, It's not just trivia, it directly links to modern practice.
Absolutely. Good hygiene, simple hand washing. It's still our best defense against spreading infections. And importantly, it reduces the need for antimicrobial drugs.
Which helps fight the massive problem of antimicrobial drug resistance.
Yeah.
If we keep our first line of defense strong and practice basic hygiene, we rely less on the drugs that are losing effectiveness.
Precisely. So understanding where an infection is happening in those skin layers is crucial for treatment.
Okay, let's shift to classifying bacterial skin infections then. It's based on anatomy, right? How deep the infection goes.
Exactly. We group them by which layers are involved and whether the body manages to wall it off or if it spreads.
So, starting superficially, or at least contained, we have abscesses.
Right. An abscess is basically a pocket of pus. It's the body trying to contain the fight. You know, white blood cells, dead bacteria, tissue debris, all walled off. Examples range from tiny superficial pustules, pimples, to deeper things involving hair follicles. A single infected follicle boil is a furuncle. If several of those merge together into a bigger, deeper mess, that's a carbuncle.
Okay, furuncles and carbuncles are contained abscesses. What about infections that don't stay put?
Those are the spreading infections. They move through the tissue layers. Some stay pretty superficial, just in the epidermis, like impetigo.
Impetigo, right, that crusty one.
Yeah. Or they can go deeper into the dermis and subcutaneous fat. That's cellulitis.
Cellulitis is pretty common, too.
Very common. And then you have the most severe category, the necrotizing infections.
Necrotizing, meaning tissue death.
Exactly, necrosis. These infections spread incredibly fast, often along the fascia, the connective tissue covering muscles. They literally destroy the tissue as they go. And a huge problem is that this destruction cuts off the blood supply. So even if you pump in antibiotics, they can't reach the site effectively. Immune cells can't get there either. It makes them incredibly hard to treat.
Right. Okay, let's talk about specific bacteria now, starting with a big one, staph. Staphylococcal infections?
Yeah, Staphylococcus aureus, it's everywhere. It lives on the skin of many healthy people, part of the normal flora.
But it's opportunistic.
Highly. If it gets through a break in the skin, it can cause anything from mild folliculitis, just an infected hair follicle, up to those big, nasty furuncles and carbuncles we mentioned.
And with staph abscesses, you often need more than just antibiotics.
Usually, yes. Because they're walled off, the pus needs to be drained. Lancing the abscess allows the antibiotics to actually get to the remaining bacteria and clear the infection.
Makes sense. Then there's cellulitis. We mentioned it as a spreading infection.
Right. Acute infection, usually S. aureus again, or sometimes streptococci, hits the dermis and subcutaneous tissue. You see that characteristic redness, swelling, warmth, and pain. It spreads, unlike a well-defined abscess.
And impetigo, more superficial.
Very superficial and highly contagious, especially among kids. Caused by S. aureus or Group A strep, you get those little blisters, vesicles that break open and form those typical honey-colored, yellowish-brown crusts.
Okay, let's talk more about Group A strep. Besides impetigo, it causes some distinct conditions too.
It does. One is erysipelas. It's another acute skin infection, similar to cellulitis in some ways, but clinically distinct.
How so?
The key is the edge of the infection. Erysipelas typically has raised advancing edges and very sharp borders. It looks clearly demarcated, whereas cellulitis tends to blend more gradually into the normal skin.
Ah, that's a useful clinical sign. And then there's the one that gets all the headlines.
Acute necrotizing fasciitis, NF, the so-called flesh-eating bacteria, mostly caused by Group A strep, though other bacteria can be involved.
What makes it so devastating?
It's the speed and the mechanism. These bacteria, especially certain strains of Group A strep, produce powerful enzymes called proteases that just dissolve tissue, fascia, fat, even muscle. This destruction spreads incredibly rapidly along those fascial planes we talked about, causing widespread necrosis. And often it comes with severe systemic toxicity, high fever, plummeting blood pressure, shock.
It sounds terrifying. How is it classified?
Our source breaks NEF down into three main types based on the microbes involved. Type I is polymicrobial, meaning multiple different bacteria working together, often seen after surgery or in patients with underlying conditions like diabetes. Type 2 is the classic one, usually caused by Group A Streptococcus alone. This is often the one associated with toxic shock syndrome as well. And type 3 is caused by Clostridium species, especially Clostridium perfringens. This leads to gas gangrene, where you actually get gas building up in the dead tissue. You can sometimes feel crackling under the skin.
And treatment has to be immediate and aggressive.
Absolutely. Massive doses of antibiotics, yes, but critically, rapid surgical debridement, cutting away all the dead and infected tissue. Sometimes, tragically, amputation is the only way to stop the spread and save the patient's life.
It's important to keep perspective, though.
Yeah.
Right. While horrific, it's statistically rare.
Oh, definitely. The source notes you're about 100 times more likely to die in a car crash. The best prevention is simple. Keep skin intact, clean wounds properly, don't give the bacteria that initial entry point.
Okay, good perspective. Let's touch on a couple of other specific bacterial infections before moving to viruses and fungi. Osteomyelitis.
That's an infection of the bone itself, often bacterial, and frequently S. aureus again, getting into the bone through trauma, surgery, or spreading from a nearby infection.
What's the main challenge in treating it?
The blood supply. Once the infection sets up in the bone, it often damages or destroys the local blood vessels within the bone tissue. This means antibiotics delivered through the bloodstream have a really hard time reaching the bacteria in high enough concentrations, what we call the minimum inhibitory concentration, or MIC, to kill them effectively. So treatment often needs to be very long, months sometimes, and might involve surgery to clean out the infected bone.
Wow, yeah, difficult. And what about leprosy, Hansen's disease?
Caused by a bacterium called Mycobacterium leprae. It's a chronic disease, not highly contagious like people used to think. You generally need prolonged close contact with an untreated individual. A big challenge for researchers is that M. leprae is one of the few bacteria we cannot grow on artificial lab media. Makes it tricky to study.
And the disease presents differently depending on the immune response.
Exactly. That's fascinating. In the most severe form, called multibacillary leprosy, the person has a very weak immune response to the bacteria, so the bacteria multiply widely. But counterintuitively, these patients often have no loss of feeling, at least initially, because their immune system isn't attacking the nerves where the bacteria like to live.
Whereas in other forms, it's the immune system attacking the infected nerves that causes the damage and the classic numbness associated with leprosy.
Precisely. The nerve damage, the skin lesions, the deformities in many forms of leprosy, it's largely due to the body's own inflammatory response against the mycobacteria residing in the nerves and skin cells.
Incredible complexity. Okay, that gives us a good handle on the major bacterial threats. Let's switch gears now. Segment 3. Viruses and fungi affecting the skin. We know lots of viruses cause rashes. Measles, rubella often coming in via the respiratory route, but showing up on the skin. But let's focus on ones where the skin is really the main event or the hiding place, like warts.
Right. Warts are caused by various types of human papillomavirus, HPV. Pretty common, spread by direct contact or touching contaminated surfaces fomites. We mostly just classify them by how they look and where they are. Common warts on hands, flat warts, plantar warts on the soles of the feet, genital warts, caused by different HPV types.
And then there are the herpes viruses, Herpes Simplex, HSV-1 and HSV-2. They cause those painful blisters. What's the key biological concept here?
Latency. That's the absolute crucial thing to understand about herpes viruses. After the initial infection, the virus doesn't get cleared from the body. Instead, it travels up the sensory nerve fibers and establishes a dormant, hidden state within the nerve cell clusters called ganglia.
So it hides there.
Exactly. It lies low, inactive. Then, later could be weeks, months, or years it can reactivate, often triggered by things like stress, sunlight, illness, or hormonal changes. It travels back down the same nerve pathway to cause recurrent blisters in roughly the same area.
Which is why treatments are suppressive, not curative, right? They can manage the outbreaks, but can't eliminate the latent virus.
Correct. Antiviral medications can shorten outbreaks, reduce severity, and decrease transmission risk, but they can't eradicate the virus from the ganglia. It stays there for life.
And this same latency mechanism is at play with the virus that causes chickenpox.
Yes, the Varicella-Zoster Virus, VZV, it's also a herpes virus. The primary infection, usually in childhood, is chickenpox. You get the itchy rash all over. But just like HSV, after the chickenpox resolves, VZV retreats into nerve ganglia and becomes latent.
And then later in life.
It can reactivate, but instead of causing chickenpox again, the reactivated VZV causes shingles, or herpes zoster. And because it reactivates in a specific nerve root and travels down the nerve fibers supplied by that root, shingles typically appears as a painful, blistering rash in a very specific pattern. It follows a dermatome.
A dermatome being the area of skin supplied by a single spinal nerve.
Exactly. So shingles characteristically shows up as a stripe or band of rash on one side of the body following that nerve pathway. Can be intensely painful.
Okay, one more virus, mainly for its historical significance, smallpox.
Yes. Caused by the variola virus. Historically, one of the deadliest diseases humanity faced. Caused horrific scarring, blindness, and killed millions. But the crucial fact here, and one of public health's greatest triumphs, is that smallpox was declared officially eradicated worldwide by the World Health Organization in 1980.
Eradicated through vaccination.
Hmm.
A monumental achievement.
Truly. Although the disease is gone from nature, samples of the virus are still kept under high security in a couple of labs, mainly due to concerns about potential bioterrorism. But naturally occurring smallpox, gone.
Okay. From viruses, let's make our final turn into mycoses, the fungal infections of the skin.
Right. Fungal skin infections, or mycoses, are generally less severe than some of the bacterial or viral ones we've discussed. They tend to like warm, moist areas. The most common group are the tineas, which are also called dermatophytoses. These are infections caused by fungi called dermatophytes.
And they live off keratin.
Exactly. They digest keratin, the protein found in the dead outer layers of the skin, hair, and nails. That's their food source.
That's why they cause things like athlete's foot and ringworm.
Precisely. We often call them ringworm because they sometimes grow outwards in a ring-like pattern, but it's crucial to remember they are caused by fungi, not actual worms.
Right. And we name them based on the body part affected.
Usually, yes. Tinea pedis is athlete's foot, very common, thrives in sweaty shoes. Tinea unguium is fungal infection of the nails, also called onychomycosis. Tinea cruris is jock itch in the groin area. Tinea capitis on the scalp. Tinea corporis on the body.
Okay. But there's one tinea that's a bit different.
Yes, tinea versicolor. This one causes patches of discolored skin, often lighter or sometimes reddish-brown. It's caused by a yeast called Molluscum globosa. The important distinction here is that Molluscum is actually part of our normal skin flora. It only causes problems when it changes form, usually due to heat and humidity. And because it's normal flora, tinea versicolor is generally not considered contagious like the other tineas.
Ah, good distinction. What about candida infections?
Cutaneous Candidiasis. This is caused by the yeast Candida albicans, which is also often part of our normal flora, especially in the mouth and gut. Like other candida infections, skin infections are usually opportunistic. They tend to occur in warm, moist skin folds, think under the breasts, in the groin, armpits, and it's a very common cause of diaper rash in infants.
Okay, so tineas and candidiasis are mostly superficial or cutaneous. Are there deeper fungal infections?
Yes, the subcutaneous mycoses. These are more serious. They happen when fungi that normally live in the soil or on plants get introduced deeper into the skin, usually through some kind of puncture wound or trauma.
And these are more common in certain regions.
Often associated with tropical or subtropical climates and agricultural work. They tend to be chronic, slow-growing infections. Examples include chromoblastomycosis, which causes these hard, warty, sometimes cauliflower-like lesions that develop very slowly over years. Then there's mycetoma. This is a really destructive chronic infection that can go deep, destroying subcutaneous tissue, fascia, and even bone. It characteristically discharges pus containing visible clumps of fungal hyphae called grains, can cause major deformity.
Wow. And one more mentioned in the source, linked to gardening.
That would be sporotrichosis, caused by the fungus Morhothrix schenkii, which lives in soil, moss, hay. Famously associated with rose thorns, hence the old name rose gardener's disease. It typically enters through a small puncture, starts as a small, painless bump, maybe resembling an insect bite, but then it can slowly ulcerate and potentially spread along the lymphatic channels, causing a chain of lesions.
Okay, that covers the fungal spectrum. So let's try to synthesize this. We've gone through bacteria, viruses, fungi.
Yeah, and the key takeaways really circle back to those classification systems. For bacteria, thinking anatomically, is it contained like an abscess? Is it spreading like cellulitis? Or is it necrotizing? That helps guide understanding and treatment. For the common fungal tineas, it's about location, pedis, cruris, and the rubium. And remembering that the really severe stuff, NF, osteomyelitis, the deep subcutaneous mycoses, almost always involves a breach in that primary skin barrier or the patient being immunocompromised in some way. The skin is the gatekeeper.
So for you listening, what does this all boil down to? We've unpacked the skin's anatomy, we've revisited the critical history of Semmelweis and antisepsis, we've walked through the bacterial rogues gallery, from superficial impetigo to the devastating speed of NF, we covered viral latency with herpes and VZV, the eradication of smallpox, and the spectrum of fungal mycoses, from itchy tineas to deep tissue invaders. This gives you that mental map, that framework, for understanding the constant microbial pressure on our body's largest, most exposed organ. And here's that final thought to leave you with, looping right back to where we started with Semmelweis. His story isn't just history. That Semmelweis reflects the tendency to dismiss new, inconvenient, or challenging evidence is still incredibly relevant today. Think about public health challenges like promoting vaccine uptake, combating misinformation, Or, very topically from our discussion, addressing the overuse of antibiotics and the slow-motion crisis of antimicrobial resistance. How often do we see that same resistance to evidence, that same reflex Semmelweis faced? The lesson endures. We have to critically evaluate the evidence, especially when it challenges our assumptions, just as Semmelweis tried to force the medical world to do nearly 2 centuries ago. It's a constant struggle. Thank you for joining us for this deep dive into the microbiology of skin and soft tissue infections. We hope it was useful. We'll talk to you next time.